طيب بسم الله والصلاة والسلام على رسول الله. Today inshallah we will have relatively inshallah light session, so we'll try to interact as much as possible. We'll see how the time goes with us, and then hopefully if you have any question toward the end, I'll try to take it. So today we will continue the topic that apparently you started yesterday, which is about allergy and hypersensitivity. Now, there is two terms here, allergy and hypersensitivity. Do you know, guys, the difference? If anyone can put in the chat, what is the difference between these terms? So we have allergy and hypersensitivity. Allergy is the response, Faris says, okay. Allergy, pathogen from outside, okay. Mustafa. Any more inputs? Okay, so allergy, Faris says, is environmental response, that's right. Very good point. Hyper excessive reaction, Mustafa says as well. So now both terms somehow kind of point toward one thing, but it's always a good idea to know the terms, what they mean, what they indicate. Allergy type 1, Nawaf says also. It can be type 1, mostly, yes, we will say. Allergy, mostly we refer to a disease. So it's a condition. Allergic, we say allergy or allergic disorders. Okay, so when we say allergy, we say it's a disease. Okay, hypersensitivity is the mechanism, is the immune response or the type of immune response. So we say hypersensitivity, I mean, okay, I'm talking about immunological mechanism. But when I say allergy, oh, this guy has, I would say this guy has suffered from allergy. I wouldn't say this guy suffered from hypersensitivity, for example. So mostly we are referring to allergy as a disease. But hypersensitivity is the mechanism underlying this disease, okay? Allergen, the one I started, yes, definitely. We have always a trigger. So allergen is the trigger for hypersensitivity. And then we define it as different kind of allergic disorders. Okay, so this kind of brief entry into the topic, just so that you know when you appropriately use which term when you talk about this mechanism. Now, hypersensitivity, there are different types of hypersensitivity based on a couple of things. We see here it's categorized based on two things. Based on the pathologic immune mechanism, what are the immune effector? What are the immune component that drive this type of hypersensitivity? For example, type 1 is driven by IgE, cytotoxic driven by immunoglobulin, as well as type 3, and type 4 is driven by T cell. So this is the only one that is driven by cells. All the other ones from type 1 to type 3 are driven by immunoglobulin. Okay, so this is the driver. This is the one that instigate, stimulate this reaction. Okay, so this is one parameters that we categorize hypersensitivity. The second is what happened. So now we have hypersensitivity response or reaction. Of course, there will be a consequences. There will be a result. There will be a pathology. There will be a tissue damage, an injury, as we see here. So the category is what happened to the tissue. And of course, we will go into these details when we discuss each of these types individually. All right. But here, kind of a summary of all the four types. It can be helpful in your studying, kind of recognize what are the differences, okay? But we will discuss each one individually. So this is the second parameter. So immune effectors involve what happens, the mechanism of the injury. There is another third parameters, which is the time of onset. Like how long does it take for this reaction and the consequences to happen? Some of them can be immediate, right after exposure to the allergen or the chemical. And some of them, no, it may take a couple of days, like this one. As the name indicates, it's delayed. It takes time, take a day or two or maybe a week to develop. But this one, as the name implicates, it's immediate, right away, within minutes or hours at max, after exposure to the allergen or the antigen, all right? And these two are in between. This one is the most variable, can be anywhere from minutes, hours to days, okay? So this is the third parameters that we categorize. So it's quite important because it's a good source for exam questions when these parameters, the time of onset, the pathology or the immune effectors involved, the drive that stimulate the immune response, and of course the mechanism or what happened to the tissue where the hypersensitivity reaction takes place, all right? So that's the kind of overall parameter that we use to categorize the types of hypersensitivity reaction. Now, there are 4 types. These are the common, the well-established. Now, if you go back to the textbooks, you will, or to the website, you will see that there is type 5 now. And the reason is because there are a lot of overlap. Now, we categorize each one here individually, looks nice. But in fact, in real cases, it's not always that clear. This guy has suffering from what's happening inside is type 2 cytotoxic only. It doesn't happen this way in the real world. Okay, so what happened? You usually get a combination. You get an overlap between a couple of these, like 2, this and this, and this and this, okay? So it is not always any clear-cut, I would say, mechanism. And that's why there are now more defining parameters that, we have now type 5 and perhaps we have more coming. So this is kind of, you keep it in mind in the future for clinical practice. Now we go to the types. So here somehow kind of a abbreviation, I would say, to the types. So the first one is anaphylaxis, and that's mean the IgE driven because it stimulates anaphylactic shock if it's not controlled. Ana means against, phylaxis means protection, and because this reaction is actually meant to protect you, but unfortunately it's a little bit over what is required. The second one is cytotoxic. The third one is immune complex because it involves formation of immune complex, antigen, antibody. And the fourth one is delayed. So this kind of helps you to recognize them. Sometimes they, Mustafa says, sometimes they add before immunoglobulin. What does it mean? Sometimes they add I'm not sure. I didn't get your question clearly, Mustafa. If you can, the letter M, is it here? Yes, here you mean like immunoglobulin M? Like this is the type of immunoglobulin that's involved. Either it's immunoglobulin M, immunoglobulin G, if that's what you are asking. So these are, we're referring to the type. You remember the 5 types of immunoglobulin? Perhaps it will become more clear. Membrane? No, it's not about membrane. Immunoglobulin is not necessarily membrane. These are just a designation. Okay, he means before, not after. I'm confused, guys. I'm not sure what you're referring. If you can, someone can speak up and clear the. Oh my goodness. Okay, let's move on, and then we'll come back to this. Just keep it in mind and bring it back at the end. All right. For some reason, I don't see a type 1 hypersensitivity explained here. I don't know why. Is it not required? Is it deleted for some reason? I don't know. So we'll start from type 2 hypersensitivity. These are the slides that we've given. We took it. Oh, okay. Great. Fantastic. That's explain it. All right, so you know now type 1 and the IgE and the mast cell and the degranulation and all the things that happen. Now we move into type 2. Now I forgot to mention, perhaps this goes all the way to the first slide, like hypersensitivity as a word. Also, I think it's kind of important to define it. What does it mean, hypersensitivity? If anyone can help. Like when we say hypersensitivity or hypersensitive immune response, can someone يعني tell me what does it mean as a term? Excessive immune response, okay. So it is actually undesirable. So it is, of course, excessive, but definitely it is undesirable immune response, okay. Now, is there a problem with the immune response or normal? Like, this is really critical key things. Do you think the immune response is normal or abnormal here? Now we say it's excessive immune response. Okay, Nawaf Ziad says abnormal. Mustafa says it's normal. Okay, Faisal abnormal. Well, of course, it makes sense to say that it's abnormal, but actually the immune system is functioning very normally. There is no problem with the immune response itself. With the immune system, we have all the cells, all the immunoglobulin, all the phagocytosis, all functions extremely normal. Huh? It's only involve the magnitude, like how much of this immune response need to be tightly regulated. I need to go to the level 10 or 100 or millions. So the immune response function very normal, and this is very key. Remember, the hypersensitivity, your immune response is normal. It's just about the magnitude. It just go way more than what is required. Okay, so try to think about it. It's tricky. Of course, there is abnormality, but not in the immune system. It's in the magnitude, because immune response usually it's about time and magnitude. يعني when this immune response has to be stimulated and for how much. And if you can imagine it as a graph, y and x, and x is the time and y is the magnitude, you can see, okay, a couple of days now we have a pathogen. Do I need to respond right away, or just wait until I see if I can control it? And then, okay, after hours, couple of hours, oh no, now I have to stimulate. It's going over control. So then I stimulate the immune response, but for how much? I mean, if I have 10 individual bacteria, it's not the same response that I would stimulate if I have 100 or 1,000 particle of bacteria or viruses, right? So it has to be proportional. Here's the core of the problem of hypersensitivity. It's with the proportion. It's just the immune response is way over sensitive. زي لما نقول شخص كده حساس، عارف انه he's very sensitive. يعني لما تمزح معاه، لما whenever he gets into problem, he's just very sensitive, عاطفي, emotional. Yes, he react strongly. يعني some people اللي تمزح معاه عادي ولا كانه يعني تعدي عليه خلاص ولا كانه في شيء. 1 minute ممكن كده ياخذ في خاطره وانتهى الموضوع. لكن that guy, he's sensitive, حساس, and that's exactly. But he's normal. I mean, his emotional, his brain, his mind, it's all normal. It's just the magnitude. Try to remember this concept. It's quite important, huh? So in general, we say the immune system is normal. Okay? Yalla, let's go to type 2 hypersensitivity, cytotoxic reactions. It's involved. So what are the effectors now we're talking about? What are the weapons that the immune system employ in order to mediate type 2 hypersensitivity? IgE, susceptibility. We said all of them are antibody except type 4. Can be IgG mostly, IgM sometime, react with antigen on the cell surface. Remember, because type 3 is antigen antibody reaction in soluble phase. Like in here, it is on the surface. So what is the cause of hypersensitivity? We will come to it, Omar. It's very complex question to answer, but hopefully we have some time toward the end and I'll explain to you. just remind me. This antigen may be intrinsic, يعني belongs to our cell, يعني part of the cell membrane, ours, okay? Right, say genetic and environmental factor, definitely. يعني this is the exact, you pinpoint the core of hypersensitivity and allergies. But there are more than that as well. But these are the two well-established cause of hypersensitivity. It can be extrinsic, circulating antigen, or hapten that attach to cell membrane. Have you ever heard about hapten? Hapten is just a small molecule, just a chemical, okay? Good. So it's just a chemical, small molecule that attach to cell membrane. Now, once it attach, now if we have a hapten only and you have an antigen only, they may simulate the immune response, but very to low level. But if you have the two together bound as a complex, then they can stimulate the immune response into a higher magnitude. So in a way, it can it works as adjuvant. Have you heard about this? Adjuvant. Adjuvant is any part that you add to the protein in order to make it more immunogenic. Yes, it's a helper somehow. Okay? Adjuvant is something that you add, and they use adjuvant with vaccines. Most of the vaccines, they add adjuvant to the protein. So أخذ one protein من البكتيريا هذه that I want to make a vaccine against. Protein itself is not immunogenic, so I add this chemical or adjuvant or hapten, and then it will increase the stimulatory effect in the immune response. All right, and why? Because they attach to the cell membrane and they make it immunogenic. It kind of tells the immune system, okay, now this antigen is clear, it's become bigger, come and attack. All right? Yes, definitely. Elicit. Now here is the summary of the mechanism. Type 2, let's go through the text first. So it's IgG mediated anti-cell associated antigen response. What does it mean? It means that the antigen is actually in the cell surface, and this response is against that antigen. Okay, so it's anti against that cell associated. So antigen on the surface of the cell, and this response or IgG is directed against. Okay, it's quite rare, not the very common form of hypersensitivity, mostly type 1, we'd say. It's most common. Immune response to certain drugs, for example. You know that penicillin, a lot of people have, they are sensitive against antibiotics. And perhaps you remember when you go to the hospital and you prescribed IV antibiotics, then they do الاختبار حساسية, they do allergy test for that particular antibiotic that you're about to be given. So then they see if you're sensitive, then they will not give you that particular antibiotics, and they will find an alternative one. If not, then you're fine to go with it. Okay, so penicillin somehow it acts as a hapten. That's what they do. Penicillin, they go and make something immunogenic. Some antigen that your immune system will just see it as fine. It's just part of our own component. But then when that chemical comes, hapten, penicillin, whatever the chemical is, then our immune system somehow said, oh, I have an antigen here. It كانت موجودة, and it was there. But until that adjuvant or hapten came, then it make it kind of elicit an immune response. So the drug binds to the cell surface, and antibody causes removal of that cell because it is tagged as a problem. So immune system will come and remove. All right. So let's go through to the mechanism here. We say IgG or IgM. So it's very important, guys, to differentiate between the immune reactant or, in another term, effectors. Very important in aspect in immunology. Always think, keep in your mind as an approach of understanding immune responses. There are regulatory mechanism and there is an effector mechanism. And of course, there is a pathology, which is the consequences at the end. So immune reactant or effectors, it's IgG or IgM, and those are the driver. Without them, there will be no reaction. This is the initiate the reaction. Then we have the antigen. The antigen can be, and most of the time, It's cell or matrix associated antigen. So it is an antigen on the cell surface. And be careful to differentiate when it's antigen or it's a receptor. So there is a cell surface receptors or cell surface antigen, and we want to differentiate between the two quite carefully. All right. Now the effector mechanism. So these are the effector components or elements. Now we have the mechanism, how these effectors molecule carry or induce this immune response. It involves complement, tamam, and phagocytosis. Complement and phagocytosis. All right. How does this happen? Let's assume that the antigen is in the surface of the platelet. For example, it can be on the RBC, it can be on another cells. But here is the example on the platelet. So what happened? This antigen, you see this in the dot, like this circle, red circle, are the antigen. And then the antibody, our immune system initiated or stimulated production of antibody that against that cell surface antigen. And then, of course, once this complex form, it will be right away subjected to phagocytosis because it's an immune complex. It means it has to be removed right away. So it will be removed by phagocytes. All right. Mustafa says cell surface does not bind to cell receptor. Cell surface. I don't know what. It's not clear to me, Mustafa. If you can rephrase it. So pathogen. Oh no, we're not talking about pathogen here. We're talking about antigens. It's an antigen. It's either ingested, inhaled, direct injection, or by digestion, or by direct contact. What does the antibody bind with? Yes, with antigen. Okay. So here it's with antigen. It's very. Let's try to zoom in. So these are the antigen, the little dots surrounding the platelets where the antibody binds. Okay. So there where these are the antigen on the surface of the cell. Not receptor. Receptor is here in the other type. So antigen, antibody. Now we have a complex. This complex needs to be removed by phagocytosis. Okay, with the help of complement. So complement, then phagocytosis. This is the mechanism, all right, of cell surface antigen. And we say in one of the examples here is the penicillin, for example, penicillin allergy or antibiotic in general. The other one is not that common, which is the cell surface receptors. This is when the antibody target or interact with cell surface receptors, specific receptors. The type of receptors will determine which organ or tissue that this antibody will attack. Is it the kidneys, for example, like in the SLE nephritis? Is it in the lung, like aspergillosis? Is it in the liver? Where? It depends on the specificity of cell receptors. It will direct certain or attack certain organ, and that will result in, of course, different type of disease. So we see it here. Again, let's try to somehow zoom in. So these are the cell. Our cell can be any organ, and now we have these receptors. Okay. In the normal case, these receptors usually will respond to certain ligand, certain chemical that attach. Usually, all these receptors is a kind of the way that the cells communicate. And there will be whatever the chemical that bind to these receptors in order to initiate cell response, either to the cell to die, or the cell to proliferate, or to differentiate, whatever the response, to secrete proteins, because these are how our cells interact with each other. If I want these cells to die, then I will send a certain molecule, I will release certain molecule to interact with the receptors, and then it will initiate a signal transduction process, and of course that will direct the cell to do something, some biological function. All right. What happened in the hypersensitivity type 2, that there is an antibody produced against our own cell surface receptors. All right. And that's kind of what we talk about autoimmune disease. We will come into these details, but now we are focusing more into the mechanism. So antibody bind to cell surface receptors. What will happen? There will be a signal transduction, of course, but mostly that cell signal transduction will lead to the death of these cells. All right, so the cell will die. And this, of course, we see it in the chronic urticaria. You know, these have the reddish, inflamed skin, itchy pumps. So these are due to the killing of our cells. Mostly, we're talking about the cell in the skin tissues, and of course in the underlying capillaries. We're talking about the skin here. So these are the two types of type 2 kind of subtypes. Most of them all have subtypes. It just determines the complexity. That's why I'm telling you it is not clear cut when I say this patient has hypersensitivity type 2 is not necessarily exactly type 2 with all these mechanisms. It can be combination of both. It's a couple of types. So usually that's why there are subtypes. Some of these subtypes now become a type by their own, individual types. And instead of being part of type 2 now, it is one of the major type by itself. That's why there is some still development in this field. All right, type 2, all good. Now we'll see examples. Now I'll try to ask you. Now we said type 1, or let's say type 2, the first and the second, antigen or receptors. Now we'll go through certain examples from the clinical practice or from the real scenario. Badr said, do the antibodies send signals to macrophages when they bind to the antigen? Definitely not when to the bind. The antibody is already bound to the antigen. Okay, this complex then will go and bind through the FC receptors, because macrophages, they have FC receptors, this receptor which antibody bind. So when the antibody complexed already with the antigen come and bind to this FC receptor in macrophages, it will stimulate macrophages to do the phagocytosis. Okay, so yes, that's how it happens. Antibody bind to the cell surface receptors, which is the FC receptor in the macrophages, stimulate macrophages to not only do phagocytosis, but also to release cytokines and chemokine in order to escalate the immune response and bring more cells, like polymorphs, for example, if needed. So they are very quite involved in the regulatory mechanism of immune response, not only effectors. Now, I'll ask you guys, these 4 examples from the clinical scenarios which demonstrate the involvement of type 2 hypersensitivity reaction. Now, the first one is transfusion reaction due to ABO incompatibility. Now, can you tell me, is it antigen or cell surface receptors? Like, it is hypersensitivity type 2, but is it directed against a cell surface antigen or cell surface receptors? Abdul Aziz says antigen. Okay, more. Faisal says receptor. Faraz, antigen. Omar, antigen. Another Omar, Abdullah, receptor. Omar, receptors. Okay. Abdul Rahman, so almost equally the response. Abdul Rahman, antigen. It is indeed antigen, because if you remember the APO system, the blood grouping system, it's these component in the cell surface of RBCs, red blood cells, which are actually an antigen. They are not receptors, but they are an antigens. These antigens define the type of group of these RBCs. Is it A or B or O? Okay, we'll see the some detail of the in the coming slide. How about RH incompatibility? When there is incompatibility in RH, it leads to hemolytic disease of newborn. Mustafa says antigen. Nawaf, Abdullah, antigen. Yes, now you got it right, because it's part of the system. So yes, RH is antigen. So it's quite important to differentiate. How about autoimmune diseases? The mechanism of tissue damage is cytotoxic reactions. Mustafa says receptor. Nawaf says receptors. Al-Bara says receptors. In fact, yes, definitely. These are receptors because it attacks one of the organs, and it is cytotoxic. All right, it will kill those cells. Don't worry about the examples. At least for me, I wouldn't ask you about these examples. SLAU to me, okay? But yes, definitely, this is the other subtype, the receptors. How about drug reaction? Penicillin may attach as hapten to RBCs and induce antibodies, which are cytotoxic for the cell drug complex leading to hemolysis. Antigen. Al-Bara says receptor. Abdurrahman says anti. If we can go back, we'll see that penicillin, some drug allergies, penicillin. So this is actual antigen. Why? Because we said it's an hapten. And hapten will make the antigens kind of more antigenic, more to be seen by our immune system. So all of them are antigens except the autoimmune diseases, which they are cytotoxic. So it's very good to be able to differentiate and know the underlying mechanism. Then I can tell, oh, okay, it's an antigen or it's a receptors. And why? Because the consequences is different. So let's see, get some of these, some details about this example. I'm sure you'll all, oh, have you guys taken the EPO system, the blood grouping? You know the blood grouping, يعني فصيلة الدم, yes, blood type. Never? Oh my goodness, okay. So we'll try to explain, except Jasser says yes. In biochemistry, it doesn't matter where, as long as you have some idea about it. Okay, so RBC, like you've been نتكلم عن فصيلة الدم, A into A وهذا B وهذا AB وهذا O, it's depend on the antigen in our blood cell surface, okay, RBCs. So blood type A, it means that these RBCs is decorated with an antigen. It's called A antigen. So A antigen on the surface of RBCs, then you have the blood type group A. طبعا in the lab it's very easy to determine. Blood group B, it means that you have B antigen on the surface of your RBCs. Blood type AB, you have both. And this one is called universal recipient. ليه? Because it can accept transfusion from anyone. هذا طبعا محظوظ هذا الشخص، يعني when he needs blood ما يحتاج ينتظر اي شيء يعطيه بلاد، اعطي A اعطي B O كله يمشي معاه. عكسه طبعا البلاد تايب او، حنعرف ليه دحين. بلاد تايب او يونيفرسال دونر، هذا عكسه، هذا يعطي يعني كريم، ده هذا بس بيعطي الناس، لكن هو صعب ما ياخذ الا من الاو، يعني he won't accept any other blood until O. وهذا دائما مسكين اللي يعني بيكون بيطول على بال ما نلاقي له يعني enough blood. دائما طبعا كمان الاو نيجاتيف اللي هي ما فيها ريتش، هذا is the most rare و it's very critical. anyway هذه بعدين ان شاء الله تدرسوها في البلاد سيستم في الهيماتولوجي بلوك in the next year ان شاء الله. طيب, so what happened here now? If you are blood group type A, يعني you have the A antigen on the cell surface, it means that your serum, yes, of course, Abdurrahman says that a lot of them, oh, it's fine, but it is, I didn't say that they are less, but I mean it's very hard to find. I'm not sure. It's a very good point, by the way. If you think that most of them, oh, then I don't know why it's always hard to find, because perhaps because it's just the consequences at the time when he needs. In the hospital, perhaps there's no much, oh, okay, the AB can't take anything, oh, I need to be careful. But this is a good point. If is most of the people are then we shouldn't have problem in finding donors, right? Like we should have a lot, but this is not actually what's happened in the but it's a very good point. يعني think about it and keep it in mind and see why this is a problem in hospital. All right, so what happened? And قلنا if you have the A antigens, right away your serum will have an antibody against what? Against B. يعني هذول complementary to each other. If you have an RBCs that has a blood type A, which has the antigen on the surface A, it means that your serum has anti-B right away. It has the antibody against the other one because the antigen is either A or B. طيب, or none. Oh, طيب. Now, if you are blood group B, that means you have in your serum an antibody against what? Against A. If you have this one, AB, that means you don't have any antibody. Otherwise, you will attack yourself. You have no antibody against A or B because you have the antigen. So either you have the antigen or you have the antibody, okay, of A and B. Blood group AB doesn't have. العكس طبعا A O عنده both anti A وانتي B. ليه؟ لأنه ما عنده الانتيجنز أصلا. فلو أعطيته A it will attack. أعطيته B it will attack. AB it will attack. That's why I cannot accept other than from O. How about A? What do you think guys can accept? Guys, لو أنت group A, what type of blood you can accept? Now remember, wait a second. A and O, Abdul Majid. Okay, all of you says A and O, definitely. A and O. Now, wait a minute. No, sorry. It's not. I'm confused myself. Wait. Now, in blood type group O, they have they have immunoglobulin, right? They have anti-O. Well, you've already cheated, guys. It's already here, right? So this is blood group A, and these are the antigen A. They have anti-B, so they can get A or O. Well, but O patient, they have immunoglobulin for against A, right? Don't they? What do you think, guys? Now, O, they have an anti, right? They will have anti-A. This one is the lucky guys, and this one is the generous guy. They have both antibodies. I'm not sure about O. We need to investigate, right? So yes, it was quite tricky. So let's think about the O. Why A can take O and B? Because the O have immunoglobulin. Anyway, if there is a miss, so here, for example, blood from type A donor. Type B anti-A, and then the recipient donor RBC will agglutinate. لأنه لما يكون عندي RBCs وantibody it will cross react أو cross linked. يعني بدل ما واحدة RBCs تيجي other RBCs, all they have this cross linking, we call it, okay? And then of course there will be clumps of RBCs and it will block the small capillaries, and that's leading to vasculitis, inflammation of the blood vessels or capillaries. Yes, will acclimate and block. Is there a function of the antigen present in RBC other than immune response to incompatible transfusion? Very good question, but I don't recall the answer, unfortunately. I would assume so, Omar, and they have functions, but this is somehow, it will be this, you ask someone with a specialty in hematology, in a blood sciences, then of course definitely they will tell you what are the functions. But I assume there are functions. I just can't remember. That will be some 20 years ago memory. It will be very hard to bring back. Okay, the second example is RH incompatibility, which is also an antigen. Hemolytic disease of newborn. Okay, have you seen this before? Like the mother, when the mother is RH negative and the fetus is RH positive. So what will happen? Fetal RBC will enter the circulation of the mother. The mother then will see the RH as an antigen because the mother doesn't have the RH enzyme. Then will trigger anti-RH antibody. Then what will happen? This antibody produced by the mother will cross the placenta and go and destroy fetal RBCs. That's why it's called hemolytic disease of newborn. Their RBCs will be hemolyzed. And they will get a... Now, wait a minute until this. So this is the mechanism, okay? Let's try to zoom in here and see. So this is the fetus, RH, it's called D also, RHOD, fetus, okay? The mother is negative. Now, this is the first pregnancy. It doesn't happen in the first pregnancy. It happened in the second. First pregnancy, what will happen? The RBCs from the fetus will go to the mother circulation. The mother, after delivery, the immune system will stimulate the production of immunoglobulin against the RBCs of the fetus, which is Rh positive. Now, in the subsequent pregnancy, the mother is already sensitized. If the fetus also was Rh positive, then the immune system of the mother already have immunoglobulin against that Rhd. Right away will cross the placenta and attack the fetus. And that will happen or result in hemolytic disease in newborns, quite a serious condition, all right? So why it doesn't happen the first? Because, you know, the immune system of the mother still takes time until it produces this antibody, and by the time an immune system, you know, the mother is kind of weakened during pregnancy, so it won't be until after the delivery that the immune system will go back to the normal, and then, well, RH is just another antigen. زي ال A will be في RH. تمام? It's just an antigen in the blood, in the cell surface of the RBCs. Now what happened? Let's see kind of more details. So this is the first pregnancy, RBCs with RH antigen, placenta, maternal circulation, delivery, first pregnancy. What will happen? These Rh positive RBCs will go to the circulation of the mother, stimulate production of B cells, immunoglobulin. Then we will have a memory cell ready. Now it's sensitized. Remember, like say type 1 hypersensitive, there is a pre-sensitization phase. Now the second pregnancy, we already have these immunoglobulin because it's already in the circulation. Memory cell right away will be activated, produce immunoglobulin. Immunoglobulin will attack the RBCs of the second fetus. All right. Now this is the problem. What is the solution? There is a treatment already, which is we treat with ROGAM. ROGAM is just an immunoglobulin. Immunoglobulin against the fetus Rh positive. So what this ROGAM has is an antibody against the Rh. So we call it anti-Rh immunoglobulin. Why? Because we want to cover the Rh antigen of the fetus RBCs so that the mother immune system doesn't see it. Okay? Is it clear? So this is the immunoglobulin, ROGAM, RHO-GAM, gamulin, something the guy who discovered it. Mother treated with ROGAM. ROGAM is immunoglobulin that will cover the Rh antigen of the fetus RBC, so the mother will not see it. What Rh mean? Yeah, we say so in the first pregnancy, but it does not know because it's still in the phase of stimulating immune response. It won't be until the second. That's why when we give this ROGAM right away after delivery, after the delivery, we'll give the mother this immunoglobulin so that in the second pregnancy, their immune system do not attack the fetus RBCs. Okay. All right, let's move on. We still have quite a bit. Oh my goodness, we are still late. The fourth is drug-induced reaction to red cells, RBCs, antigens. We have these molecules like a drug, hapten, absorb drug to drug or drug metabolites. It will be absorbed, like attached to the antigen, and then of course we will activate the antibody production and complement and then phagocytosis, which is the first type of the type 2. Now, hopefully that wasn't quite complex, but it will be, inshallah, digested easily. Type 3 hypersensitivity is also known as immune complex hypersensitivity. Why? Because it involves the formation of soluble antigen antibody. So it's not in the cell, it's not in the tissue, it's soluble in a liquid phase. The reaction may be general. Serum sickness is when we are given immunoglobulin for passive immunity. Then you get serum sickness because of reaction against that immunoglobulin, or involve organs, and you see a lot of examples here. Now let's see the mechanism, what happened. It's variable in time, it's 3 to 10 hours, so somehow intermediate. It is mediated by soluble, as I said. This is a key word, soluble immune complex. They are mostly IgG, it can be IgM. The antigen may be extrinsic, يعني something outside of our body like viral or bacterial infection, or intrinsic, and this is the case of autoimmunity against our own organ, the systemic, the SLE, for example. You can see now SLE type 3 and type 2, both are involved. That's why we say it's not clear cut, that in each condition there is only one type. Immune complexes can become deposited. These complexes, they go deposit in the wall of a small capillary leading to immune response. And let's kind of see it here. So this is the first step. We have antigen and immunoglobulin, all right? Antigen antibody complex insoluble, يعني في liquid environment. Of course, the B cells was initially activated in the sensitization phase. Now, what will happen? This antigen antibody complex will be precipitated at the surface of the endothelium, all right? This precipitation will activate complement and inflammation. What the result of inflammation is vasculitis. The endothelium will be heavily inflamed, and there will be proliferation and growth of the cells underlying the endothelium. This is related to vasculitis. All right. So this is how it happens. Of course, brings inflammation. So complement, antigen antibody soluble, complement, deposition in the cell in the endothelium, and inflammation of the interior of the vessels, vasculitis. Okay, 1, 2, 3, as simple as that. Okay, so this is type 3, and then of course it's kind of more explanation. Locally injected antigen in immune individual with immunoglobulin antibody pre-sensitized. So these are the antibody, these are the antigen. It will happen complex. This is what we talk about. Complex away from cells, not on the surface of cells or anything. It's soluble, free. What will happen? Complement activation, number one, complement activation. Number 2, induction of inflammation. So there will be an infiltration of white blood cell, macrophages, neutrophils. They will leak from the capillaries and goes to the underlying tissue. So let's say, for example, it's in the skin, and then you get inflammation. See, all the skin here is fine, and then you get inflamed. Local inflammation, increased fluid and protein release, phagocytes, everything will be leaked from the capillaries, goes to the underlying tissues, and this will cause inflammation. You see how the heavy vasculitis, it's an ischemic representation of the blockage of these receptors. Now, I'm not going to ask you about this type of immune complex disease, persistence, inhaled. For me, I will not. If you want to memorize it, it's up to you. You get question, I'm not sure. But it's for me, I will not. Last type, type 4, hypersensitivity, also known as cell-mediated, is the only one cell-mediated. All the others are antibody. Delayed, it takes long to develop, caused by production of antigen-specific effector T cells. The only one, all of them antibody. Here now we have effector T cells. It's involved in the pathogenesis of many autoimmune disease, infectious disease, tuberculosis, leprosy. All these infectious diseases has one thing in common. Can you guys tell me? What do you think? Tuberculosis, leprosy, I'm sure perhaps you haven't studied this microbiology yet, but the common things about these microorganisms, these are all bacteria, parasites, and so on. They are intracellular. They go inside what? Inside macrophages. They can resist phagocytosis. They get inside our immune cell, and they can survive the killing. Okay, so that's why our effector cells will need to destroy those cells. So this is an example. Now, we have 3 subtypes. Okay, one is driven by T helper. So this one, T helper, either subset helper 1 or 2, or by the cytotoxic lymphocyte. In terms of the cytotoxic lymphocyte, there is a cell-associated antigen, and the immune mechanism is cytotoxicity. Straightforward. These are the cell. For example, the transplantation. Let's say you have been transplanted. They have a foreign antigen in this organ. Then cytotoxic lymphocyte will come, recognize this is foreign, and it will kill it right away. This is what's called graft rejection. هذا الرياكشن اللي بيصير لما when you are transplanted. Okay, those two, these two involve soluble antigens. Okay, and here what will happen? Either we activate macrophage, and this is the common, or we activate immunoglobulin E, and this one somehow close to the type 1. That's why I'm telling you now there are a lot of overlaps generally associated with type 1. So we will forget about this one and focus on this one only as type 4, which is driven by Th1. What will happen? Activation of macrophages. So this is T helper 1. It will go and bind and then activate. What will happen? Macrophages will release. Yes, Ahmed, thank you for reminding of the time. I'm going to finish by this slide. Contact dermatitis, tuberculin reaction, and these are kind of the example. This one, of course, mostly associated with type 1. This one, there is nothing new here other than explanation of the antigen, the consequences, what happened. Again, this is a somehow graphical representation. Maybe we will stop here, and tomorrow we'll kind of revisit from 16, huh? So remind me tomorrow to start from slide 16, 17, and 18, and then we'll go to the second session. Okay, but this is a kind of explanation of type 4. Can you repeat graft rejection? How about tomorrow عشان البريك؟ خلاص, I'll leave you now, guys. وإن we'll cover, we'll repeat those tomorrow, whatever you need.
دكتور
تفضل.
دحين في التايب 4 هايبر سنسيتيفيتي انت قلت انه الباثوجينز اللي موجوده فيها تقاوم الماكروفيجز والنيوتروفيلز وتدخل جواتهم. طب هي ما تدخل جواتهم اصلا عن طريق الفاجوسايتوزس؟
عن ايش؟ لا مو عن طريق الفاجوسايتوزس. It penetrate, it inject itself. They have injection mechanism. Okay, so they are not went there. They didn't get inside by phagocytosis. Otherwise, they have been killed. Okay, so they got in by penetration, huh? So they kind of penetrate the phagocytes, and even if they were engulfed by phagocytosis, let's assume, okay, then what will happen? I mean, some of these micro organisms, they get inside by phagocytosis. Still, they can resist. They have a mechanism that resists the killing, the bactericidal molecules inside the macrophages. Okay, so these yes, they can resist killing.
يعني لو سووا ريزيستنس للي اسمه الفاجوسايتوسيس المايكروفيجز والنيتروفيلز حتتركهم ولا هي تبدا تدمر الRBC cells?
No, they will stay there in order to replicate. So any pathogen, any bacteria, any virus, when it gets inside our body, the main aim of this organism is to increase in number. This is يعني همهم الأول, to replicate. فهذول they will get inside. لما they get inside macrophages, why they do that? It is a mechanism of hiding from the immune response. So they are not eliminated. They get inside the macrophages. طبعا our immune system will not think that these macrophages will be infected. So how you infect an immune cells? This is a problem, and this is what happened with HIV when they infect CD4. So this is become troubling. That's why these infections usually result in a chronic form of infections. They're very hard to eradicate, very hard to treat. Why? Because they hide, they trick our immune system by infecting their component. All right, so they get inside, they replicate. They don't replicate to high level. Why? So that our immune system doesn't notice. It's very, they slow down, they replicate very slowly until they increase in number without giving the immune response a notice. This is very smart of these microorganisms. We'll come into this when we study microbiology. All right, so yes, they get inside, they replicate. تفضل.
Mediated type 3 hypersensitivity. معنى mediated the one that initiate the sequence.
Let's quickly go so I can see it. Is it here?
Second point.
Mediated. It is mediate. Yes, definitely. So these are the factors that initiate. Yes, mediators means the components or the the factors that initiate or stimulate the process. Okay, we call it mediators. تمام. Okay, for the time's sake, we will conclude